the ventriculitis associated with hydrocephalus due to the sequelae of meningitis. If you are having a color flow, then we also can see the pyogenic collection and the debris, low debris seen in the ventricles. This is the pus collection. You can see in ventriculitis plus hydrocephalus. Low level echo collection seen in the ventricles, floating debris, highly suggestive of a pyogenic collection. Then high flow, due to increased flow, hyperemia, and then we can see also the hydrocephalus. So all this thing we can immediately see what is the sequelae of meningitis which is taking place due to this infection. Then again, there is a long-standing infection, then long-standing outflow tract obstruction result into the gross hydrocephalus. You can see here, these are the strands which are floating in the ventricles, highly echogenic wall, and this is the gross hydrocephalus you can see here. This is a follow-up case of tubercular meningitis, where we can see a dilated ventricle, shifting, distorted anatomy, and resulting into the pressure on the brain parenchyma, thinning of the brain parenchyma. So these are the cases they immediately require a shunt. They immediately require, so that we can prevent that cross damage to the brain parenchyma. Not only that, we can see the gross hydrocephalus. Due to this, again, we can see the gross hydrocephalus, and then this is a big porencephalic cyst. You can see here, this is the pressure over the ventricle. This is again, you can see a huge hydrocephalus seen in a case of 1.5-year-old child, which was the fontanelle was open, and it was also a sequelae of the ventriculitis. What happened? There was a big focus on an abscess that resulted into the gliosis of that brain parenchyma, and that gliosis led into the communication between the ventricles and resulted into the porencephalic cyst formation. Same thing, what you can see the lateral ventricle, and it is seen as communicating with the porencephalic cyst. This is the communication between the porencephalic cyst. Again, you can see this is a 2-month-old child. This is a dilated frontal horn. This is a communicating porencephalic cyst in a case of post-sequelic meningitis. Then not only that, we can see at times the obstruction due to a different level, and this is the case where we find the aqueductive stenosis. This is a dilated ventricle, this is the third ventricle, this is the foramen Monro, and this is the aqueduct of stenosis. So this is again leading into the obstructive hydrocephalus, and these patients need the shunt operation. Then not only that, at times we can get the cystic infection. This is a thalamic cyst. Again, gross hydrocephalus. This is the thalamus. This has gone due to the ischemic insult. Due to the ischemic insult, flow obstruction to the thalamus, we got the ischemic necrosis, resulting into the thalamic cyst. And this is a choroid plexus cyst, which is an incidental finding. What we can see, and this is the choroid plexus, and this is the lateral ventricle, and this is small cyst which is seen over there is a choroid plexus cyst. Then we can see the infections in utero. What we are saying, toxoplasma, ventriculomegaly, cerebral basal ganglia, and periventricular calcification. This is the periventricular calcification what we are seeing here with hydrocephalus, and this is the basal ganglia calcification with hydrocephalus. This is due to the in utero infection, the toxoplasma, rubella, or torch infection, what we can call a cytomegalic virus. Periventricular calcification, herpes simplex, cortical calcification. These are the highly echogenic focus seen in the basal ganglia, and this is the toxoplasma where we can see the periventricular calcification. Then IVH, the premature babies which are who are born around less than, you can say, 32 weeks or between 32 weeks or 28 weeks or below 34 weeks, the germinal matrix is very fragile, and this germinal matrix, due to sudden asphyxia, slight ischemic insult, starts bleeding, resulting into the intraventricular hemorrhage, or known as, these are having 4 types of the hemorrhage grading. One is the subependymal hemorrhage. Grade 2 is the IVH without ventricular dilatation. Grade 3 IVH with ventricular dilatation. Grade 4 IVH with periventricular hemorrhage and infarction. Then intracerebral hemorrhage, this is very uncommon. And here we can see a ventricular hemorrhage, you can see here. There is not much dilatation of the ventricle, but we can see a hemorrhagic focus here. But there is, of course, we can see gross dilatation of the ventricle with a floating clot. This is a hemorrhagic clot, it's a grade 3 hemorrhage, this is a grade 2 hemorrhage, and these are the hemorrhage in the patient of IVH. Then gross hemorrhage we also seen here in a highly white chalky dense ecogenic hemorrhage filling whole of the ventricles, seen here, and this is a big intracerebral hemorrhage you can see here. This is a parietal hemorrhage what we are seeing. This is a gross hemorrhage in the ventricles, and this is a big hemorrhage in the parietes. Not only that, due to the birth asphyxia, we can get in the premature baby increased incidence of cerebral anoxia, resulting in the small ventricles and ill-defined ecogenic areas in the cerebral cortex with focal or diffuse distribution known as the brain edema. And what we get, if we get a thalamic focus, then the prognosis is very poor. The sequelae result into the cerebral atrophy, fluid collection in subdural interhemispheric fissure, dilated ventricle with small head. And if this anoxia is sustained for longer time, resulting into the ischemia and then resulting into the anoxia, resulting to gliosis. So this is the birth asphyxia, diffuse highly ecogenic pattern seen in the parietal lobe. Pressure, this is the birth asphyxia. Pressure due to this edema, brain edema, pressure obliteration takes place in the ventricles. The ventricle gets, due to sudden swelling of the brain, there is pressure obliteration of the ventricles. Highly ecogenic distribution seen in around the parietes. Here you can see in the parietal lobe. We cannot see obliteration of the cavum septum pallidum, obliteration of the ventricles due to the brain edema. So all these things usually we see on ultrasound, and we can immediately say this is the birth asphyxia. Then trauma. We are doing now a lot of cases. This is small child who sustained trauma, a 1 month old child fell down from the cot. There is small swelling. The thing is okay, fine, but this swelling was there and it was very tender. The baby started crying when you touch it. When we did ultrasound, we found that there is a fracture of the outer table of the parietal bone. You can see how beautifully it is picked up. This is the fracture site, and these are the outer table of the parietal bone. Then we can also see the subscapular, due to trauma we can see the scapular hematoma formation. Fortunately, the outer table is absolutely intact, you can see, but this is a scalp hematoma. This is picked up on high resolution ultrasound in a patient, only 6 days old infant, again who sustained scalp trauma, and you can see outer table is absolutely fine, and there is a scalp hematoma only. But here there is, you can see, a fracture of the table. Not only that, we can see localized hematoma formation in the scalp in a 3-month-old child. You can see here, which undergoes, there is a long-standing chronic hematoma which undergoes the liquefaction. So this is long-standing. There was a history of trauma, but the swelling was there, which was there, sustained there, and this is a long-standing trauma which underwent into liquefaction. Then, this is a very interesting case. Actually, this boy, when he was brought to us, he was already deeply comatose. He was 4-month-old child. No, it was 2.5-month-old child, and he was deeply comatose. I took detailed history. They thought it is some congenital problem. When I asked the mother, I persisted asking on mother. I found this child is baby, this Ali. The mother was very specific that when the baby was born, it was absolutely fine. She told me on my repeated examination questioning, she told me the baby was absolutely fine, was crying, moving hands, throwing arms, saying here and there was no question of any coma. What I found that you can see a big subdural hematoma over there. Can you see here? And this is the bleeding vessel. Then this whole of the brain is shifted. You can see here. And this is the CT scan which confirms the diagnosis. Actually, this is chronic hematoma, somehow which was ignored by the treating physician, and that kept on bleeding, pressing over the parenchyma, and ultimately leading to the baby coma. And this was a collection. We did also, this was loss of the big mass effect, shift, obliteration of the ventricle, cross brain edema, and this is the ultrasound which showed immediately. I did ultrasound, then I asked this clinician, I want to do a CT because I am suspecting a big hematoma. You can see here. And this is the CT, and this is the ultrasound. So at times the detailed history helps you. This is again the same type of the case where we could not help. That baby was saved because we could drain the hematoma. There was not much of the damage to the brain, but this was a hopeless situation. Again, we did an ultrasound on a baby who was comatose. There is a big hematoma which has shifted whole of the brain parenchyma, you can see, and this is the CT. What happened? This hematoma kept on increasing. Nobody thought it. They thought that the baby is having some congenital problem, and whole of the brain parenchyma got shrink. This is counter-current effect. This is pressing over here, this is a collection, and this is story. Unfortunately, the brain parenchyma damaged to that level that it could not be salvaged, and this baby then after intensive care, after 2 or 15 or 20 days, this died. So what I mean to say, we should not leave these situations. We should take a detailed history. If parents are very confident that baby was born normally, and then after 15 days or 20 days they started developing problem and went into delirium or semi-coma or coma, then we look for certain coma stage. Then ultrasound also helps in the brain masses like cystic masses, solid AV malformation, forehead cyst I already told you, arachnoid cyst, middle cranial fossa cyst. Solid masses are rare, but we do get that, like lipoma, choroid plexus tumors, papilloma, and ependymoma. Then AV malformation, aneurysm of vein of Galen, which I already told you, and calcified Ehrlich-Weber syndromes. You can see again a big aneurysm of the vein of the Galen. This is the color Doppler, and we can see a papilloma of the choroid plexus, and then we can see a glioma over here. This is a glioma. This is a papilloma of choroid plexus. This is aneurysm of the vein of Galen. So, just to conclude this, we can see high resolution sonography of the neonatal brain is one of the integral part of the neonatal care unit. It is very versatile, easy and rapid investigation to examine sick babies without dislodging them from the intensive care unit. Easy follow-up, cost-effective